Good afternoon, and for those of you just joining us, welcome to our webinar on protecting healthcare workers from the hazards of toilet plume. I'm Diane Rains, a former chief nurse executive and the current assistant professor of nursing at Jacksonville University. Our healthcare workers are the backbone of our medical system. It's imperative that we protect them from unnecessary health risks. We certainly learned that in our COVID days. Today's webinar will focus on one such risk, toilet plume exposure. We will delve into the science behind this issue and discuss practical solutions to safeguard our healthcare heroes. Before we begin, I would like to review some CE information for you. This program is approved for 1 contact hour of continuing education by the California Board of Registered Nursing. To earn CE credit, you will need to document your attendance to establish your eligibility, and that will be done at the end of the webinar. The code you see now will be the one you will see at the end, which you can scan when this session is over. Let's look at our objectives for the day. So we're going to summarize the potential health risk of healthcare worker and patient exposure to toilet plume containing bioaerosols and hazardous drugs. We'll identify pathogens and hazardous drugs that are excreted in urine and feces, describe the mechanism of toilet plume aerosol creation, and then discuss strategies to minimize the bioaerosol and hazardous drug contamination in patient rooms. We will allow time for questions and answers at the end of the program, and you may ask your questions through the Q&A button at the bottom of your screen. And as we said at the beginning, the chat box is disabled, so it's the Q&A that you will work with us with. So with that, it's my privilege to present our first speaker, Dr. David Nash. Dr. Nash is both an MD and an MBA and is a board-certified internist. He is the founding Dean Emeritus of the Jefferson College of Population Health on the campus of Thomas Jefferson University in Philadelphia. He remains there on full-time faculty as the Raymond C. and Doris N. Grandin Professor of Health Policy and Medicine. Dr. Nash is celebrating his 35th anniversary on the faculty. And he certainly doesn't look that, I've noticed. He's best known for 2 major career contributions of many. One, as one of the founders of both the movement to improve quality and safety in healthcare, and the second, to herald the advent of population health. He is the editor of the best-selling textbooks in both quality of care and population health, and he remains the editor-in-chief of 2 scholarly journals, including the American Journal of Medical Quality and Population Health Management. Dr. Nash has authored more than 100 peer-reviewed articles and edited or written 25 books. His most recent book, How COVID Crashed the System, A Guide to Fixing American Healthcare, is now in its 3rd printing since its publication in 2022. And I just want to tell you, I bought one on Amazon today and they said it was the only one left. So I see another printing coming soon.
Okay.
Dr. Nash has received many national and international awards, and he has 3 honorary degrees. He's lectured in more than a dozen countries around the world. And finally, he's an expert in both for-profit and not-for-profit governance with over 20 years service as a hospital trustee and 10 years on the board of Humana. He's been married for 45 years to Dr. Esther J. Nash. They have 3 grown children and 3 grandchildren. Dr. Nash, we welcome you as our first speaker.
Diane, thank you. And special thanks to all the team that put this together. And thanks to Leapfrog, especially, and Splash Blocker. So listen, wow, a lunchtime presentation about toilet plumes. Yikes. I mean, you got to be devoted to even consider a subject like this. But I want to especially thank the team from Splash Blocker for the last 5 years. I've known and been taught by them about the risks that we all really are involved with in taking care of patients, especially in an inpatient setting. And we've got 2 experts who will be introduced in a moment. I've reviewed all their material. This is going to make your hair stand on end. The broader topic here, and something that Leapfrog knows an awful lot about, is that being at the bedside is dangerous. And sadly, in America's most important and largest industry, the healthcare industry, we still don't have the kind of protection that people have in factories and other settings. And certainly we all remember what happened during COVID, lack of personal protection equipment. But I go back to needle sticks at the beginning of AIDS and all the other issues. So being at the bedside is dangerous. What we've come to learn, especially in the last 5 years, pre-COVID, is that there are other risks involved that we never really gave much thought to. And when you learn about the size and scope of the plume that shoots out of a hospital toilet 6 feet into the air, and when you recognize that even after we clean a room, that you think you're protected from C. difficile, well, you're not. And if you think you're protected by wearing PPE at the bedside, guess what? You're really not. And so I find this to be very sobering, very scary. And I hope in the next 45 minutes or so, you'll not only appreciate the science behind this, but then the health policy that has to follow from the amazing science that these experts have been working on for years. So in summary, I'm thrilled to be a small part of this. I've been working on the quality front for 3 decades. And sadly, we still have an awful lot of work to do. And I consider this as part of that future agenda. So thanks again for joining us. Not exactly the best lunchtime topic, but honestly, folks, you're going to be scared by what you see. And that's part of our goal today. So thanks again.
Thank you, Dr. Nash. You're right about being scared, and I would say that we've practiced for many years, and what we don't know won't hurt us. And now we know, and we're going to know more by the time we're through today. So thank you so much for your introduction. Our next speaker will build upon what we've just heard. Tamara Beam is a master's prepared nurse with over 18 years of nursing and 14 years as an infection prevention specialist and leader and consultant. She's published in multiple professional publications, including APIC and ARN, and is a fellow with APIC. She is an advocate for patient safety and believes that preventing infections is within everyone's reach. Her passion resonates within her roles as she mentors other infection preventionists who are eager to learn and grow in their profession. She most recently started her own infection prevention consulting business to help others with survey readiness, sterile processing, or high-level disinfection concerns, and with anything else in the infection prevention-related world. In her spare time, she enjoys her 4 grandchildren and doing triathlons. Tamara will share her perspective as an infection prevention specialist. Welcome, Tamara.
Thank you for that warm welcome, and I'm so excited to be a part of this team. I thank Leapfrog for giving us this time to share Seth's and my professional view on this topic, and I'm excited and a little bewildered that the amount of years that I've had in this profession to just finally be awoke to the topic of its caliber, which I'm going to share with you today. But welcome to this wonderful webinar. I'm excited to share with you some insight from an infection preventionist perspective, why it is so imperative that we look deeper into and closer into our toilets in healthcare, and the toilet plume and the possibility that it could be an absolute factor contributing to the cause of many of the infections in our inpatient populations. So let's take a closer look at the evidence, right? We're nursing, we're physicians, and we're in healthcare. So we do look at evidence-based practice. Over the years, you're right, that's exactly what I just said. Over years that some of us infection preventionists and hospitals have overlooked. So join me. As an IP, we're on the constant hunt looking for what haunts all of our different units of our hospital, for what causes different hospital-acquired infections, what we often term as HAIs. Is it the cleaning of a room or the lack thereof? Is it hand hygiene and the missed opportunities by staff and physicians and ancillary folks? Have you even considered the toilets in your units? Are they behind bathroom doors? Are they shared toilets? Do you have shared rooms, bed A, bed B? Do they flush the toilets with your patients sitting right next to them while they're in the shower, maybe? Is the door still open, or is it an open unit with the toilet integrated into the space? I used to work at a very old ICU in the middle of Leavenworth, Kansas, where our toilets were little like latrines inside the room. For example, does it recognize or does it look like the ICU toilets in a Mathers study from 2018? In the Mathers study, there were hoppers, just like I described, in all the ICU patient rooms. Those hoppers had no covers. And if you look at all of the toilets in healthcare, actually in almost every public bathroom, there's no covers on the toilets. Mathers showed that the hoppers contributed to KPC. So that's your Klebsiella pneumoniae, and it's a carbapenemase type of Klebsiella, being possibly aerosolized into the ICU unit after implementation of an automated hopper closer and other interventions. It decreased the incident of hospital-acquired infections in their ICU. Interesting. So now we all know that one of the biggest culprits we all think of in infection prevention and in healthcare is the fecal oral nightmare of all HAIs. That's Clostridium difficile, or C. diff. So let's revisit how long different organisms such as bacteria, different virus, and spores can live on dry hospital surfaces. So C. diff spores can actually live on surfaces for greater than 5 months. The Acinetobacter species can live anywhere from 3 days to 11 months. Enterococcus species, including vancomycin-resistant enterococci, can live 5 days up to greater than 46 months. Yes, you heard that right, 46 months. Pseudomonas can live on a dry surface for 6 hours to 16 months. And staph can live, including MRSA, for 7 days up to 12 months. And the ever-living norovirus can live 8 hours to greater than 2 weeks. I don't know how many of you have ever had norovirus in your department, fighting it in a particular unit where staff, like to continue to come to work. But norovirus can continue to live in an department depending on how many people continue to come to work, right? So when we think about the prevalence of HAIs possibly being linked to toilet plumes and the bioaerosols of feces being blown up into the air, it is very, very possible to think about that toilet plume causing that fecal oral transfer of those types of organisms, such as norovirus and C. diff. Pretty scary. So what is really amazing is this article from the American Journal of Infection Control. This is like the Bible for us IPs, okay? This is something that I get on a monthly basis. I read through it, articles that pertain to maybe something that is going on in my particular hospital or something that is of interest to me. And I will read those articles on occasion. I don't always read the whole thing. I'm very honest about that. I read what interests me at the time. And to be very honest with you, I did not read this article from 2018. I read this article specifically when I wanted to understand more about toilet plumes. So what's interesting is this article is by Athine, Cooper, Lynch, and Johnson. It was written in 2023, and it showed that C. diff spore contamination in the toilet bowl, in the toilet bowl water itself, after being inoculated, generated an aerosol even after 24 flushes. That's pretty incredible. With spores still present in the bowl after the 24 flushes. So, for example, you're going to worry about that affecting future patients in the room, right? That's pretty scary because, for example, if that patient's only there for a couple of days, that spore is still in the toilet bowl. So, furthermore, the droplet nuclei spore bioaerosol was produced over at least 12 flushes. So the study showed a persistent source of C. diff contamination from the environment over an extended period. Pretty scary, if you ask me. So now, in a scientific report that was published by Corey Bowles, Grant Brown, and Matthew Noneman, when flushing a toilet, we all know the power of a hospital toilet, right? For example, if it flushes and you're still sitting on it, that's a problem too, right? Because you get sprayed. We all know the power. So as much more force than your home toilet. So I worked in a hospital years ago, again, when I talked about one hospital that I worked in. I had a staff outbreak and patient outbreak where we had a lot of people getting sick quite quickly. So I quickly pivoted. I made cleaning changes. I increased my bleach. We did all of these things where we cleaned our high touch surfaces. So our handles with bleach. I had staff staying home. I said no more potlucks. And people kept getting sick. So I began to have a theory about our ill patients that were coming in. So back then, we didn't have a lab test for norovirus. And most hospitals still nowadays don't have a lab test for norovirus. We test for C. diff, we test for other stool pathogens that are pretty common or actually fairly virulent, right? Norovirus is something that pretty much just passes. It's pretty supportive. You just do a lot of fluid support and it passes. But there's other things that need more support. And those are the type of pathogens we normally test for. So we did not test for norovirus. So I suspected that our diarrheal patients that were coming in from the community were C. diff negative, were probably norovirus positive. So they were probably exposing my staff, which were then becoming sick, right? So when they would flush their poo. So what I did was we actually had one of those shower devices that would like fold down into the bowl as they would flush, and they thought that that would kind of clean everything out. And what I realized was that that was probably the fecal oral transmission in the plume that was washing that hat and that was like flying back up on my staff. Like, gross, right? That it was probably just flashing them in the face. So the study above that we're talking about here, when you think about those pathogens, that study found about the same type of issue, that flushing suggests that the viral pathogens, such as norovirus, can contribute to human exposures. I stopped my outbreak by tossing all of the hats that I had in the toilets that had any type of poo in them into biohazard bags. And we would flush with our feet instead of our hands because I had no idea what else to do to protect my staff. And we did PPE. We did face shields, we did face masks, we did all these things to try to get people to be safe because we had no idea what else to do at the time. So here I am to tell you today about, along with the rest of the presenting team, that we have a huge problem. This is a photo from a 2020 study at the University of Colorado, where when a toilet was flushed, the plume itself was sent 6 feet into the air. It spread 65 square feet wide and was proved to be suspended for 7 days. The videos are gut-wrenching, which you can actually watch online. Another study to prove this has been known for quite some time is from the UK from 2012, folks. It shows a toilet plume of 9.8 inches above the toilet, and it took 60 minutes for the bacteria to decrease in the surroundings by 8-fold, and 90 minutes for them to decrease by an additional 3-fold. So you may be asking yourselves the same question I've been asking for years. Why are there not covers on hospital toilets like we have at home? Well, for mobility reasons, hospital toilets, as well as many other locations, do not place covers on the toilets. And there's no future plans to put covers on toilets. From an infection prevention perspective, though, I'm rethinking that process in my mind that although mobility is important, preventing patients from infections is also equally important, if not life-saving. So in the American Journal of Infection Control, there's an article and a systematic review that showed that this is an understudied space and that the transmission link is still unknown. There could still be a huge risk to workers, patients, and the public for infectious disease from medications and other organisms, including the poo we just talked about. And there's no evidence of the absence of a health risk. So this brings me to an emerging and infectious disease publication in 2020, where there were 2 cases of documented patients acquiring healthcare-associated Legionnaire's disease. These cases were both in France from the same hospital, from the same room, but these patients were hospitalized 5 months apart from each other. With the help of genome sequencing, this testing showed that these isolates were identical from the toilet. Odd, you may say, right? I know at my facility, I have never looked for Legionella in the toilets. The Legionella was not in the shower, was not in the sink, it was not in the water towers when tested, only in the toilet. The Legionella pneumophila could have and must have clearly led to the exposure through the flushing of the toilets, through the shared room 9 months apart. So let's tackle this image from the article by Patty et al., printed in the American Journal of Infection Control from 2023. Looking at a patient's environment from an infection prevention perspective, this room should look pretty familiar to you. Look at this picture. We look at our isolations. Let's think of this room like isolation for infection prevention, right? We know that we place a flu patient on droplet isolation due to the droplets that can land on surfaces. We also put our TB patients or rule out TB on airborne due to tiny particles, right? They're suspended in the air. We also ensure that isolation rooms have minimum air exchanges for negative pressure, and we test those rooms yearly. We also test the water in our rooms, our water towers, high-risk areas, and have a water management program. Do you test your toilets too? Should we test our toilets? Now that you're learning about toilet plumes and how far and wide they aerosolize into the space around your patient and the patient room, what do you think? Look at this picture. If you flush the toilet and the flush plume puts those particles all over the toilet, the walls, the floor, the toilet paper, and particles continue to float through the air as bioaerosols, then we have a serious problem, Houston. These images show you the description or the depiction of the areas we often underestimate as the location for various spaces of contamination for C. diff. The walls, the toilet handle, the toilet paper roll, floors, assisted bars, commodes, armchairs in the room, bedside tables, bed rails, and other areas in the room, especially if there's a self-flushing toilet in the room. Keep in mind the images above of contamination are in a room that had a routine cleaning and is a non-C. diff patient room now. Scary? With a C. diff contamination, the alcohol-based is the second most contaminated site recovered in a 1,000-bed acute care hospital, the toilet, right? So this was a study done to see the amount of C. diff contamination that could be found in the environment around and surrounding the patient. The alcohol-based dispensers that were not automated, right? So the ones that you kind of have to push with your hand. The alcohol-based dispensers that were not automated were also documented as being contaminated with C. diff. When isolation measures were stopped for this patient, the room still showed C. diff contamination. This shows that I'm not only doing a terminal cleaning of the room, and even then, that may not be enough with the bioaerosols that could have been dispersed into the room. So we have some more evidence-based practice for you here. A study published in 2020, 2021 Gerba et al. Showed that there is contamination under the rim of the toilet that persisted for up to 50 days. I think we all know this is even in our own home toilet, which is a little scary for me. I'm going to go home and clean my toilet again. I think we all know this even our own home, but when we go on vacation, for example, we come home to a ring around the toilet. Their study indicated that the pathogenic bacteria and biofilm found is greater in numbers in that biofilm than in the water itself. This would show then that flushing and the subsequent plume would then aerosolize that biofilm of enteric bacteria into the surrounding airspace and deposit all around. If we don't clean the bathrooms with disinfectants and only use soaps or detergents, we are missing the opportunity to destroy the spread of these deadly viruses and bacteria throughout the restroom. Now, the most recent literature and studies out there are going to be discussed all day today during the webinar and in the coming months. Released this year in the American Journal of Nursing is the evidence that aerosol plumes may result in the inhalation of respirable particulates containing bacteria, viruses, or hazardous drugs such as chemotherapeutics. That is really scary. This can lead to their deposition on surfaces that may result in dermal contact as well. Wow, just wow. If you have not read this article yet or seen the videos, it is so important for you to see and read the science in depth about what we are up against here and how important this new evidence shows that we have some work to do, not only to protect patients, but staff as well. And the CDC is now making guidance and an argument for mechanical covers for hospital toilets. If a hospital has a hopper to install mechanical toilet covers for flushing, but keep in mind, mechanical covers might be really, really cost prohibitive for hospitals. Plus, we have to think about mobility issues for patients, and this might be limiting. They used as a reference to make this suggestion the Mathers article for 2018 for the KPC and the ICU wastewater. But we have all been following COVID in the wastewater, so this is not far-fetched, right? But we also know that our patients have MDROs, CROs, CREs in their urine and feces, and we know that C. diff and norovirus is in our wastewater. So it begs to be studied how our toilet plumes are affecting our patients and contributing to our hospital-acquired infections, leading to hundreds and thousands of deaths annually. How will you make a difference in your facility moving forward? I'm going to defer to Seth, and he's going to talk more about this.
Thank you very much, Tamara. Well, you've certainly ruined any lunch I was thinking about having. And honestly, I think I worked in that same ICU. I remember those hoppers and what looked like camper bathrooms in the room. I can only imagine. And think about as nurses, how many times we cannot get the infection under control. And who do we go to? We say, housekeeping. You need to do a better job in here because surely it must be you. The other thing I would point out, Tamara, is your title alone demonstrates the progress that has been made. Because years ago, you would have been an infection control nurse. Now you're an infection preventionist. Because we know so much more. And your question about, now that we know, what are we going to do about it, is kind of the key question. And so with that, it's my pleasure to introduce our last speaker for today, who is well known in oncology, medicine, and nursing. Seth Eisenberg is board certified in both oncology nursing and bone marrow transplant and has been an oncology nurse since 1983. His experience includes 36 years in bone marrow transplant at the Fred Hutchinson Cancer Center in Seattle, including 25 years in ambulatory oncology infusion. So Seth has gained his expertise not only through education, but through experience. He has authored numerous peer-reviewed articles and several book chapters, 2 of which are in the 2024 ONS Safe Handling of Hazardous Drugs book. His national and international presentations have covered a variety of topics at pharmacy and nursing conferences. His awards include the 2017 March of Dimes Research Advancement Award, the Susan Baird Excellence in Clinical Writing Award, and the 2021 Distinguished Award for Consistent Contribution to Nursing Literature. While officially retired, he continues to consult and advocate for nursing and patient safety. So Seth, we're looking at you for our answers.
Thank you, Diane. Appreciate that very much. So just briefly, before I get started here, I wanted to mention I'm going to be covering specifically the oncology side of things, but I'm also going to spend some time talking about the mechanics of how these aerosols get out of the toilet, because Tamara did a great job of talking about projecting these bioaerosols. And I'm going to go a little bit deeper into the bowl, so to speak, to talk about how do they get out of the bowl. So stay tuned for that, if I can get this to advance. Okay, I'm going to start off with actually a definition here, because I'm going to talk about hazardous drugs. What do those mean? So for those of us who are not in oncology, these are drugs that have been defined by NIOSH as having any one of these 6 properties. The first 5 actually go back to ASHP, our pharmacy organizations. And then NIOSH added the last bullet, which basically says if it walks like a duck and quacks like a duck, we're going to call it a hazardous drug. So that's when I talk about hazardous drugs, mostly chemotherapy, but not all of them are. We got a lot of antivirals that are also hazardous as well. So this slide demonstrates the side effects of exposure. And this is exposure that was documented in nurses and pharmacists who were handling these drugs without proper PPE back in the 80s and 90s in particular. And if you look at the list on the left side here, this list looks pretty similar to the kinds of side effects I would expect to see in my patients who I was giving chemotherapy to. Not surprising. The list on the right, though, are things that we don't necessarily see in patients, but were identified in the nurses and pharmacists who were exposed. And some of these are actually pretty devastating if you look at them. The last bullet here is, to me, the most disturbing, which is a study that showed learning disabilities in offspring of women who were pregnant and exposed to chemotherapy during that time. So this affects basically all of us. It's not surprising if we think about how do these drugs work. Chemotherapy does not really kill a cell. It interferes with the chromosome's ability to replicate, so the cell can replicate. So to that end, Christine Roussel did a wonderful review published in 2019, and she found 17 studies that showed a very significant association between exposure to these drugs, people working in hospitals and pharmacies, and increased damage to the chromosomes of those employees. Now I want to pause and clarify this. What this really means is that what they found is the longer someone had contact or exposure or work history with these drugs, the more the damage. So for somebody working a year and getting off and doing some other kind of employment, not so much, but people who had 10, 15, 20, or like myself, 40 plus years of exposure, that's where the damage was even worse. And this is akin to us saying smoking a single cigarette is not going to give you lung cancer. It's the chronic exposure to these carcinogens that results in chromosomal damage, and that results in cancer development. So this review was really on the nose. Okay, I'm going to hopefully move on here if I get this. So if we look at the drugs that we use to treat cancer, several of them are actually known carcinogens, which is a crazy irony if you think that we are treating cancer with drugs that can cause cancer. But again, these drugs work by altering the DNA in those cancer cells. We also have a number of drugs that are suspected carcinogens as well. And I'm going to get this out of the way just in case this is interfering with your screen. Okay, so how does this occur? Well, we know that dermatologic contact, absorption through the skin, is the primary source of absorption of these drugs. However, we also have data that shows that inhalation of these aerosols can also occur. And one of the things that we'll be specifically talking about here today is toilet plume aerosols rather than these other sources. So because of the dangers that we know about with these drugs, there's been a lot of guidelines written. We have to go back to ASHP and Bruce Harrison in 1981 for that. And then shortly afterwards with Lucy Power out of UC San Francisco for coming out with the foundational guidelines for handling these hazardous drugs There's been decades of guidelines. 1984 was when the Oncology Nursing Society, or ONS, came out with its first edition of the Safe Handling of Hazardous Drugs, edited by Marty Polovich. We've had several other publications since then. I think most of you should be quite familiar with the USP 800. That's an entire topic that we could spend a few hours talking about. I won't go there today. But I do want to point out this ONS Safe Handling is that we're now on the 4th edition of this book. I have been privileged to be a contributing author to the 2nd, 3rd, and 4th editions of this book, specifically writing chapters on the administration of these drugs and post-administration issues, which covers excreta, which is here we are today. So part of what I'll be talking about today comes right out of this book. Okay, what's in your toilet? Well, let's dig a little deeper, so to speak, and find out what's in your toilet. So one of the things I want to really emphasize here is that the drugs we give to patients, and specifically in this slide, we're talking about hazardous drugs, are excreted in urine and feces. The amount of drug that gets excreted depends upon the specific drug and how it's metabolized, but this is just a sampling because the list is very long and wouldn't be legible on a slide here, but it shows that it can be up to 95% of the drug is excreted, and a lot of these drugs are excreted unchanged, which means the drug that I have given through an IV infusion is coming out identical in the urine, ending up in that hat in that toilet, getting dumped into that toilet water here. And some of these are pretty staggering. If you look at 90% of methotrexate comes out unchanged in the urine. That really emphasizes how important this is and what we're talking about in safeguarding our staff. So wipe testing, which is when we actually will surface wipe an area, send it off for analysis to see and get a quantification of how much drug is present. Wipe testing has shown that there's hazardous drugs in bathrooms. And in fact, there's a study that I published a couple of years ago that would just make you sick. If I had time to give you the details, I would. But the bottom line is that it showed we did a patient bathroom in my infusion room at Fred Hutch, and we did a staff bathroom. We found chemo on the floor in both bathrooms. I mean, and we tested for 5 days in a row, twice a day. It was really quite an eye-opener. So we know that the contamination exists. We know that the surfaces can include the toilet rim and seat and handle, which Tamara showed us in that one slide with the bathroom schematic and all the areas that are contaminated. Not surprising. While we as nurses are supposed to be wearing gloves, and I think most nurses do, when we handle urine in the bathrooms, we can still get touch contamination. I have personally witnessed and seen also reported in studies where this contamination on the door handles spread by contact, whether that's contact with hazardous drugs or by bacteria that is on the drug and transfer from surface to surface. The other two things I want to mention, number one, is that nurses, we don't normally wear respirators in patient bathrooms. Now, there's a lot more respirator use now that we had the pandemic, but again, we're not wearing them to flush. The other thing is, even though I'm wearing PPE as prescribed by the guidelines, we're not wearing hair covers. So those aerosols that can go up to 6 feet in the air and hang there, when they start settling down, for those of you who still have hair, they can end up in your hair. And we're not protecting our staff's head. Now, I'm not advocating head covers. I'm going to advocate something else instead. But that's just something to be thinking about here. Okay, let's talk about the generation of those aerosols in terms of how they happen. And I subtitled this slide, "Who Let the Drops Out?" Because really, how are they getting out of the toilets? So I want you to focus, first of all, on the picture on the left side of your screen. Remember that hospitals use high-pressure toilets with flushometer valves. Those are the silver or chrome handles we push down on. Very different than the gravity-fed toilets in residential homes, and that's a different subject. But looking at hospital toilets for the moment, we can think of those as essentially the same as a large volume nebulizer. Now, if you're not familiar with a nebulizer, it's a device used to deliver medications for asthmatics. Those of us who have asthma have seen way too many of these. But basically, you put a medication into the bottom. the middle chamber rather, you hook up high pressure air or oxygen, it creates a vortex with that medication, and then it's inhaled through the mouthpiece. That's the whole idea of a nebulizer. The picture on the right shows you a toilet and how it behaves just like a non-therapeutic nebulizer. We have high pressure water that enters the bottom of the bowl. It creates a vortex in the liquid, and then the aerosols are forced up through the opening, not different than the mouthpiece on the real nebulizer. So that's, in essence, simplified version of how those plumes, we saw that picture of John Cremoldi out of Colorado with the lasers shown on the toilet and how those come out. This is the mechanism of how those are launched. And Cremoldi is a physicist, and this is what he wanted to look at, is those vortexes and how they get out. Again, we've already talked about these vortexes and the aerosols and how long they stay suspended. I'm not going to repeat that too much here. So here's some flushing facts. This is a really geeky slide, but these are important, and I'll try to get through this and then show you why this is important. So we know, and I'll show you the data we collected, we know that hospitals generate particles from about 0.02 microns to 10 microns in diameter. Particles smaller than 5 are referred to as respirable because we can inhale those, and those smaller than 2 are referred to as alveolar because they can go deep into our alveoli in the lungs. Particles larger than approximately 5 will fall to the floor and other surfaces, and that's how we get contamination in the bathroom, or one of the mechanisms of contamination. And then one study showed that almost 7 mils of liquid is launched out of a toilet in the hospital after each flush, with droplets landing more than 4 feet away from the toilet, which is pretty staggering. Okay, I drew this picture here to show you when I talk about diameter of a particle, that's a pretty abstract number for most of us. So I'm talking about particles down here, size of a coronavirus to a C. diff spore and other bacteria. So that's how small we're talking about. And the fact that it's this size ties right back to what Tamara was saying about launching these particles out of a toilet and basically aerosolizing our bathrooms with the microbes that could be in there. These are much smaller than even a white blood cell, which is, again, not visible to the naked eye. That's how small these particles are. Okay. I'm going to take a closer look now at some research because I really want to emphasize what do we know in research studies rather than, okay, what's this person's opinion or this is anecdotal. I'm going to give you some good research to chew on here. First, we're going to start off with actually a non-scientific survey that was done at the Oncology and Nursing Society Congress back in 2022. We asked 4 questions to nurses. There were 217 nurses who just randomly wandered by and participated in the study. So when we asked them their level of concern with toilet flushing, basically 90% were either highly concerned or just very concerned about that particular problem. Many of them commented that they would flush and rush because they knew that stuff comes out of them. Nurses who wore dresses or skirts would comment on the fact their legs would get wet when they flushed. We asked then also how many use a plastic-backed pad because ONS has been recommending covering with a pad for many years now. And so we asked that question. And about 1/3 of the nurses said they either always or almost always used it, 2/3 saying they didn't. And when we asked them why they didn't use it, the number one answer was that the pads tended to get sucked into the toilets. More on that in a few slides. We asked them if they used a respirator, and 13% said yes. This number, I think, reflects the fact that we're in the post-COVID era. If we would have asked this question in 2020 or 19, that would have been 0. I guarantee it, because I can tell you we didn't place N95s in patient rooms and fit tested the entire nursing staff prior to the pandemic, except for very specific patient populations. And last, we asked what was their biggest concern. Not surprisingly, with an oncology population, 76% hazardous drugs, but a lot of them were still very concerned about bacteria and viruses. Okay, This is the article that Tamara mentioned earlier. And if you do nothing else after the end of this webinar, I implore you to get this article from AJN and review it. We published this back in April of this year. And this was a study that I did with Anne-Marie Walton, who's a colleague who's done tremendous amount of research and publications in the effect of hazardous drugs and safety of nursing assistants, specifically in her hospital. She works at Duke and did all of her research there. And then my third author, I have to mention Tom Connor. Tom, an esteemed colleague who for many years was the head of NIOSH's Hazardous Drug Safety Research Department. He published all of the guidelines that we currently use out of NIOSH. So I need to give kudo out to Tom on this. And the conclusion, after looking at all the research going back over 20 years, was that there's sufficient evidence to again show that flushing an uncovered toilet is a potential risk for healthcare workers. Okay, now, this is an article that, or a study rather, that we did back in, published in 2022. And this was designed to look at, well, okay, let's confirm the problem, and then let's look at what do we do about it? Because we can sit here and talk about the issue to the next presidential cycle if we wanted to, but we really need to be talking about strategies on how do we deal with the issue. So this was done in a laboratory. So I'll show you pictures in a second here. And the goals of this study were to measure size, number, and mass of these particles. We wanted to see if we could visualize the larger particles and evaluate the effectiveness of a solid reusable cover. And I got to mention Chanji Kai, who is a professor out of University of Oklahoma. Chanji is an aerosol biology researcher, and the laboratory that we used, he designed specifically for research for NIOSH, rather for OSHA and NIOSH during the pandemic, to look specifically at the spread of COVID on airplanes. So this is what we used. This was the laboratory. This was a HEPA filtered test chamber. Inside we had a hospital toilet. This one also has a mannequin in it, which we had other test equipment hanging from her to measure different aerosols at different heights. And this is just a close-up of what it looked like over here. And this was published in JOEH, I should have added here. Results: the uncovered toilet produced thousands, not hundreds, thousands of particles of different sizes over 5 minutes. The highest concentration was within the first 90 seconds, which, as a bedside nurse, I wouldn't spend more than 90 seconds in a bathroom. I certainly wouldn't spend 5 minutes, but we wanted to see what happened at 5 minutes because some of the older studies looked at it for that length of time. And the bottom line was that covering the toilet with a solid reusable barrier significantly reduced the number of particles. This is a graph from the article that shows you the reduction. Without a lid was the blue line, and the gold line showed you what the amount of particles or the concentration of particles were when we covered it. And you can see the huge difference there. So this is a picture using fluorescein, which is an indicator dye that we added to the toilet water, and then we used an ultraviolet light. And this is a picture of the underside, the bottom side, the toilet side of fluorescein droplets under ultraviolet light, showing you this is what's stuck to the bottom of that reusable cover. So these are the droplets, the visible droplets that would come out of the toilet had the cover not been here. And in fact, we flushed it with fluorescein and without the cover, and we were able to identify droplets on the floor of the bathroom. Unfortunately, I don't have those pictures here on the slide, but those droplets, the visible ones, got out. What we don't know is what happened to all of those particles that were invisible, that are inhalable, respirable particles. Okay, after that study, I went back to Chanji. I said, you know, Chanji, there's another study I want to do. I said, I want to compare that solid reusable barrier, because it was pretty effective, to what ONS had been recommending, which is those blue pads, the disposable pads, to see what the difference, if any, was between the two of them. So we wanted to compare the efficacy of those two interventions. Again, want to find out what can we do to reduce this problem and stop it at the source. So we used those two interventions, we used the same exact laboratory setting, and we compared it at 16 inches and 40 inches to replicate another study that was published. We did this one with a portable optical particle counter, and the reason we chose this device will become apparent in the next study I will talk to you about. This is just a picture of the OPC measuring the uncovered toilet and measuring with the solid removable cover here in place. So what do we find? Well, both interventions reduce the particles by greater than 99% with a p-value smaller than 0.05 at both heights we measured. However, the other thing we observed, which is very interesting, is that every single time we flushed with the plastic pad, it got sucked into the toilet as shown in this picture here. Now, I want to stop for a second because some of you may be thinking, wait a minute. We've been talking for the last 25 minutes about spewing particles like the Old Faithful geyser at Yellowstone. How can you tell me it's being sucked into the toilet if particles are coming out of the toilet? I'll explain that to you. So when you first flush a toilet, whether it's a residential or a hospital toilet, the first thing that happens is you get a siphon effect. As the water leaves the bottom, it creates negative pressure. Negative pressure, if you recall your physics, will draw everything down towards it. Well, if you've covered the toilet with something, it's going to draw that down as well. And what we saw was exactly what those nurses at the conference had told us about, is that it pulls the pads into the toilet. And the question is, now what do? Are you going to stick your hand into the toilet to pull it out? It's dripping wet. What do you do with it? It's going to drip on the floor. You've got to put it into something. If your patient was a C. diff patient or the patient was getting chemotherapy, you've got that debris on the bottom side of that particular pad. What are you going to do with it? Most nurses have tried to flush it down, which plugs up the toilet, and that's a whole separate issue for the engineering department here. So this is a huge issue. The other thing I want to mention is that in this picture, we even tried this with an extra large sized blue pad. This is not the size that I would use in the hospital. It's much smaller than that. We thought, well, maybe a bigger pad, because of the weight of it hanging over the front of the toilet, would keep it from getting sucked in. Still got sucked inside. So that was very interesting results. And this was published a couple of years ago, or a year ago, rather, sorry. All right, last study I'm going to talk to you about, and this is huge. This is hot off the press, meaning this actually came out in JOEH in October of this year. Huge study. So those studies were all done in a laboratory, and I said, Chanji, we need to do something that's clinical, because it's one thing to do it in a laboratory. I want to see real life, not just one hospital. We want to do multi-hospitals. So we designed a multi-center study. This is 15 US hospitals in 9 states. And we traveled from the East Coast to the West Coast, from southern part of Texas to Minneapolis. We did 9 states. 7 of those hospitals were designated NCI designated comprehensive cancer centers. We flushed and measured 145 toilets. So I was joking. I said, well, at this point in my career is definitely in the toilet, literally. So, but because we were traveling, we couldn't drag all the laboratory equipment, hence the reason for using that optical particle counter, which we validated its effectiveness and accuracy in the last study. So we brought it with us, mounted it on a tripod, so measured it so that it was at the same height in every single hospital we visited here. We did HEPA filtered departments, non-HEPA filtered departments. We went to ICUs, oncology units, medical surgical, mixed units, orthopedic. We even did pediatric and adult units in all of these toilets that we did here. So we really wanted to look at influences. I also wanted to see, was there a difference between flushing on the 3rd floor of a hospital versus the 12th floor of the hospital? Does it make a difference? And how effective was this reusable solid cover in all of these environments, not just a laboratory? And was it similar to the results we were getting? Here's the results. We anonymized all the hospitals for their protection, of course. What we found is a mean reduction in toilet plume aerosols of 99.98% with an incredible p-value to show you that, yes, covering made a significant difference. Now, we learned a lot about ventilation in bathrooms, and we can talk more about that later if there's time. But this is just proof that, yes, there's a problem in hospitals across the country. It doesn't matter where your hospital is located. And yes, using a solid reusable cover reduces it by 99%, which from my perspective is like the flush never happened. The amount of particles in the bathroom after the flush were virtually identical to what we started with, what we call the ambient number of particles there. All right, last couple slides here, and then we're going to open it up to questions. So how do we integrate this into practice? It's not as complicated as we may think it should be. ONS says in their guidelines, excreta safety should be part of all hazardous drug handling activities, meaning that this shouldn't be some separate weird thing we do in oncology. Specifically, this is something that should be part of everything else we do. They recommend covering the toilet before flushing for patients receiving chemotherapy. I would propose to you that based on what we know about the biological impact of viruses and the bacteria that was already discussed, that this should be done on all units, not just oncology. We just don't have these kind of guidelines that cover a variety of units in all the hospitals. But a toilet is a toilet is a toilet. They're no different in the med-surg unit than it is in the oncology unit. They're still the same toilets. So there are currently two options for covering. People said to me, well, you don't talk about the options. I'm going to make sure I talk about them here. There are only two viable options: the plastic back pads, and there's several brands on the market. Many of you may know Chuck's. It's one of the brands out there, not designed for this purpose, but it is definitely being used for this purpose. And the other product that's specifically designed for this purpose is Splash Blocker. There may be other things coming down the road, but right now, these are sort of the two choices out here for doing the reduction. And I can say that both of these at least have had research showing you what their efficacy is. Okay, we need to do our question and answers first. So Diane, it's all yours.
Thank you very much, Seth. And I apologize to the group that you were not enthusiastic in your presentation.
I'll try harder next time. I will.
Please.
I'll have to have more coffee next time.
Next time. So I hope that you all have learned. I've learned much today just listening to this. And I do want to point out two things. The Splash Blocker, which we have talked about, was designed by an oncology nurse. And the research that you have seen over these past few minutes also was heavily influenced by nurses. And so kudos to our colleagues who are making a difference in this way. The other thing, for those of you that are responsible for recruitment and retention of healthcare staff, the fact that you would be interested in preventing their exposure to the things we've talked about today is an asset, and could be labeled as such, because our nurses they've got it with infection and oncology. They understand what's happening now. And so just another thought. Okay, we've had several questions answered already, and we have a couple more that are unanswered. We're going to go another 2 to 3 minutes. We recognize that we're a little over, but we want to make sure you get your questions answered. So one that is open is the ROI and benefit data, so that the IPs can make the case for adoption to leadership. I wonder, Brian, I know you're on the call. I think you might be the best one to answer that, perhaps. And while you're thinking about the answer, what I would say, and Tamara as well, Seth, if you guys, Dr. Nash, because this is the ROI here covers more than just the cost of the material, right? So it covers what happens to your staff and the cost of them getting sick and the cost of them leaving the profession. So do our speakers want to address that?
Yeah, let me jump in and let Brian take a moment. So I think there's lots of both direct and indirect costs here. Of course, the direct cost is a staff member who gets infected and is out. And the risk to the other members. And of course, the indirect are all the issues around are we working in a safe environment? Do we feel that the culture of where we work protects our well-being? I think that's incredibly important. That has implications for recruiting, work satisfaction, reducing burnout. I mean, these are all the things that, notably are super important, sometimes difficult to put a dollar sign in front of.
And the other piece, in order to figure out return on investment from an IP standpoint, if you have a data mining system, I really would press your data mining system to pull some type of data that would directly associate your length of stay of your patients to your HAIs. So most facilities have an average length of stay. They can tie your HAIs to what that increased length of stay is. Then they tie that increased length of stay to what that cost is for those additional days. They tie that to the HAI directly. Then you have your never bill events. You can look at what your never bill events are and see what that is. Then you can directly look at the cost, for example, of your HAIs that are waterborne organisms or your C. diff or whatever it might be. It's really, really difficult to say specifics, but if you have a particular infection that you're having a lot of issues with that are in an environment that are up to and close to, for example, a toilet that you think that it could be being caused by the plume that we're talking about, I think that if you did some type of trial to look and see whether or not there is a case for improvement, the cost that you're talking about to improve or to even look into seeing whether or not this would make an improvement, the costs are extremely minimal in relationship to the cost of an HAI. Because we all know that the cost of an HAI, whether it be C. diff or otherwise, is exorbitant. We know that it's quite high.
And I would just, if I can add one thing to that, I agree with what everyone has said on this. And I chuckle a little bit about ROI questions just because it pokes me the wrong way. So what's the ROI on the millions of dollars we spend on giving our nurses chemotherapy gowns or chemotherapy gloves rather than cheap gloves? What's the ROI on what we spent on N95s during the pandemic and isolation gowns and laundering those gowns? It's hard to sometimes put those things into perspective when the bottom line is, are we protecting our staff, and is it the right thing to do to keep our staff safe? So, okay, I'm going to stop right there.
You can't put a price on patients' lives.
You can't put a price
exactly
on.
Thank you both. And so we've had a couple of questions about attendance. And so the QR code is up for you that you can record your attendance, and that's how your CE will occur. I think the only thing I would add to ROI that you guys haven't is all hospitals now are measured on their infections and their quality control. And there's a definite ROI to doing well or poorly on those. So that's just another thing that you could add to your, your thoughts around that. I would like to thank our speakers today, Dr. Nash and Seth and Tamara on an excellent presentation. We'd like to thank the Leapfrog Group for being the sponsors for this today, and Splash Blocker for bringing this research to the forefront. So we hope you've learned something. We hope you have a great afternoon. And I understand from looking at the answers to our questions that the slides will be available. So they'll be there for you to help you. And I'm sure both Seth and Tamara would be willing to consult with you further if you needed that.
Yep,
so with that, thank you very much. Have a wonderful afternoon.